Good evening. I'm going to be discussing the stroke case study. I have a 76-year-old man who was slightly confused. His wife brought him in, described his symptoms started about 30 minutes ago. He had a sudden onset of difficulty getting his mouth to form words. Speech is slurred. Face and mouth numb. Tongue feels thick. He's unable to hold his coffee cup in his right hand. His right leg is weak. He needed to hold on to the table in order to stand. My differential diagnosis at this time, based on the information I have, is that he is suffering from a metabolic or toxic insult, such as hypoglycemia or drugs, a traumatic event such as an intracranial bleed, whether it be epidural or subdural, meningitis, a brain tumor, primary cardiac event with hypotension, a primary seizure disorder, especially with Todd paralysis, or a migraine. Some of the other questions that I would ask would be what his normal baseline is like, what other medical conditions, if any, does he have a history of anything like this ever happening, does anyone in his immediate family have a history of medical problems, has he suffered any sort of recent head trauma, does he drink, smoke, use illicit drugs, have there been any other points in time that he exhibited weakness or frailty on one side or the other. The additional history I was given is that he has history of essential hypertension, which is uncontrolled. He has not been taking his medications, especially his diuretic thiazide. He says it makes him feel bad. He was told his cholesterol was high, but he has not returned to see his primary care provider. He has experienced several spells of right-sided weakness that resolved in few minutes, though thought his arm was only falling asleep. He has had no head trauma or recent infections. He has a family history. His mother died of a stroke. His father died of an acute myocardial infarction. He smokes 1 pack a day for the past 30 years and leads a sedentary lifestyle. Having learned what I have about this patient, I think now we were able to remove a few of the differential diagnoses and push for the patient to be taken to the nearest stroke center. However, while we're waiting for the patient to be transported, I will continue to do my assessment. My physical assessment now shows the patient's alert and anxious. He has slurred speech, but he uses appropriate words. He has temperature 37 degrees Celsius orally, respiration 16 and regular, heart rate 86 and irregular, blood pressure 190 over 120 in the reclining position. His head, eyes, ears, nose, and throat, conjunctiva are clear without exudate or lesions, fundi are without lesions, nicking or cotton tufts. Nasal mucosa is pink without drainage. Oral mucous membranes are moist, no lesions. Poor dentition. His pharynx is pink without lesions or exudate. His skin and his neck pale with senile lentigens, no lesions or bruises. No tenting, dry and flaky. Supple, no lymphadenopathy or thyromegaly. He has bruits auscultated over the left carotid artery. His lungs, chest expansion is symmetric and full. Diaphragmatic excursion is equal to 4 centimeters. Lung sounds are clear to auscultation. His heart sounds irregular rate and rhythm. No murmurs, gallops, or clicks, though. His abdomen, non-distended bowel sounds are present and hyperactive. Liver percusses 2 centimeters below the right costal margin, but overall is still 12 centimeters in size. He has no tenderness or masses and no bruits. Extremities are cool but good cap refill at 3 seconds. 1 plus pitting edema of bilateral ankles. His radial artery pulse is full and equal. Anterior pedal pulses are diminished but equal. No clubbing. Neurological exam, however, even though he's alert and oriented, he does have a facial droop on the right side with a loss of a nasolabial fold. He has a diminished gag reflex. Strength is 3 to 5 in the right upper, 4 to 5 in the right lower extremities. Yet it is 5 to 5 in the left upper and lower extremities. His deep tendon reflexes are 1 plus on the right, 2 plus on the left. His sensories are intact, though, to touch without neglect. Studies that I would order while I was preparing for my interventions, I would ask for the initiation of laboratory studies, radiographic studies, and an EKG. I would ask for a complete blood count, a comprehensive metabolic panel, a brain natriuretic peptide, a coagulation panel, a blood sugar level, and an EKG, and a CAT scan. What therapies would I initiate immediately while awaiting the results of the lab studies? Because of the vital signs and the EKG findings, the lab results, and the neurological exam, I would immediately discuss the use of thrombolytic therapy, the administration of a beta blocker or antihypertensive, as well as a diuretic. The lab results have come back. EKG showed atrial fibrillation. His serum glucose was 130 milligrams per deciliter. His coagulation panel showed 12.5 seconds to 28 seconds on the PT, PTT respectively. His platelet count was 220,000, and a head CT scan without contrast did not reveal evidence of a bleed. He was in turn taken to the emergency department. The risks and benefits of thrombolytic therapy were explained to the patient and the family. His neurological status did not improve. However, his blood pressure got better with the use of labetalol. Physical exam, once again, his vital signs show 170 over 86, so his blood pressure improved. His heart rate is 100, however, and it is irregular. Neurological examination, alert and oriented. He follows commands. His right hemiparesis is worsening now. Strength is 2 out of 5, both upper and lower extremities, yet it is still 5 out of 5 on the left. He has moderate dysarthria and decreased sensation on the right side. So what do I think is happening? Why is the hemiparesis worsening? What does the CT scan mean? Should you continue to his hypertension treatment to bring it down to normal? I believe this patient is potentially suffering from a cerebral thrombus that was undetected in the scan. The hemiparesis is worsening because either the clot is traveling in the cerebral vasculature or the clot created an aneurysm which may have potentially busted, and this has now become a hemorrhagic stroke. The initial scan performed only shows the fact that there was no active bleeding in the brain at the time, which would allow us to utilize thrombolytics. However, the antihypertensive medication should in fact be continued. What intervention would be initiated now? As far as further interventions, a repeat scan would be performed to ensure that there is no actual hemorrhaging in the brain prior to administration of the thrombolytics. A consult to neurosurgery for the potential placement of a bolt to prevent an increase in intracranial pressure in the event we were unable to use thrombolytics. Now what should be done and what can the patient expect? With no bleed discovered on a repeat scan, the administration of thrombolytics can begin. The patient can be admitted to the hospital with neuro checks in place, as well as the administration of an ACE inhibitor to control the hypertension and digoxin to control the atrial fibrillation, as well as an anti-aggregate such as aspirin to prevent further development of a thrombus. The patient could benefit from an echocardiogram to reveal a possible source or the cause of this issue. While in the hospital, the patient does well on the digoxin for his atrial fibrillation. He converts to normal sinus rhythm at a pulse of 82 when regular. His cholesterol is still elevated with 270, and his high-density lipids are 25, a ratio of 6 to 6. Antihypertensive therapy with an ACE inhibitor is initiated, and an antiplatelet therapy use of 325 milligrams of aspirin has begun. His hemoglobin A1C is 6.8. He has not smoked while he has been hospitalized. Cardiac echogram was performed. It was normal. He has no mural thrombus. However, a carotid Doppler showed 40% stenosis on the right and 50% stenosis on the left with no hemodynamic changes. At this point in time, excuse me, he is not a candidate for carotid endarterectomy at this point in time. What instructions and medications should this patient go home with? As far as instructions and medications, when discharged home, the patient would strongly benefit from no longer leading a sedentary lifestyle. Secondly, the use of low-dose aspirin, low-dose digoxin, and lipid-controlling medications and an antihypertensive would be very beneficial. In the event that the aspirin regimen would not be successful, then the use of stronger blood thinners such as Coumadin, warfarin, Plavix, or Xarelto could be considered. This would more than likely be the way to go since the carotid Doppler shows substantial stenosis in both the left and the right side. What steps can be taken to prevent a future attack? Steps that the patient can take to prevent future attacks are to remain compliant with their medication. Secondly, the cessation of smoking would benefit him as well. And lastly, try to incorporate diet and exercise into his daily routines.